Hello, everybody. Let's get started. So we're going to obviously talk about pain management and pain care here. We're just going to highlight the objectives. There's no way you haven't seen articles upon articles in social media about the current opioid epidemic, so we'll chat about that for a little bit. And then I'm going to go through some case studies to really, try to exemplify and show what kind of gaps and issues might be present in managing pain. Then we'll take a look at the various professional organizations, government agencies, and see what they've put out recently on pain management, and of course talk about risk management strategies. There's almost an overwhelming amount of information out there, and yet folks are still not relatively educated. So we'll start with, so we're all on the same page, talking about how you define pain. And you can see this goes back to the late 60s, early 70s, where it really started to gain some momentum. And it's, we know this to be a subjective experience. It's whatever the person says it is and whatever they say it is. And it should be patient-centered because of that. It can also incorporate sensory and emotional experience with the actual or potential tissue damage, as we all know. It's very complex. So it's multidimensional. This is not an easy topic. When you look at the different types of pain, a lot has changed over time. So what was once acute pain's definition really had to do with terms of duration, and now it's a really complex, defined as a complex, unpleasant experience with emotional and cognitive as well as sensory features that occur, in response to tissue trauma. Then if you look at chronic pain, that was once defined as pain that extended 3 to 6 months beyond the onset of the beginning reason that it started. And it's defined as persistent pain that disrupts sleep and normal living, degrades your health and your functioning ability. Cancer pain is pretty self-explanatory, or malignant pain as it's sometimes called. It's associated with potentially life-threatening conditions. But then there's the chronic non-cancer pain, which is something that is more, that's a newer term for providers over the, several last years, because it really has to do with there's a weak relationship between the tissue pathology and pain levels. It's prolonged. It's potentially lifelong pain. So, it's an impact on your activities of daily living. It can be fierce, and some examples are osteoarthritis, low back pain, and fibromyalgia. So let's start out with what's happening with the current epidemic. One of the first set of guidelines and warnings that came out was in 2009, and it came from the American Pain Society and the American Academy of Pain. And it talks about here what the difference is that it was starting to be okay to prescribe pain medications beyond the cancer pain and some of the other more obvious sources of pain. This was really a growing acceptance with professionals that these drugs could relieve non-cancer pain, and they created some guidelines because of this. So it could be used for low back injury, accident, trauma, crippling arthritis, sickle cell, etc. But there still was concern even then about a widespread, opiate abuse, addiction, and diversion. I mean, today even opiates are used for pain after and during childbirth, without even thinking of suggesting alternative treatments. So obviously opioids are very valuable drugs. I mean, there are certain types of pain out there that this would be the only way to help folks. But unfortunately, we're at a point now where there's an average of 44 people who die each day from opioid abuse. They've quadrupled since 2000. The rate of opioid-related overdoses and deaths in rural counties is 45% higher than in the metro area. They often have an older population. A lot of the jobs out there are maybe more physical, leading to more work injuries, and the distance for them for addiction treatment is just ridiculous, if any at all. So 50% of Americans now have been touched in some way by the abuse of painkillers. I know there's one county in West Virginia where the overdose rate is 81 per 100,000. And when you look at their most urban area in West Virginia, the rate is 35 per 100,000. Obviously, getting holistic care is nearly impossible. Often the best that they can do in the rural areas is offer a hotline for addicts. There's such a stigma, too, and it's even harder for those in the smaller communities where everyone knows everybody. I mean, there's fear if I go seek help. Other people might know, they might see my truck at that doctor's office. I know that in some areas, the Hospital Engagement Network in a rural state that I work with, they're tracking Narcan on inpatients just to see if there's a trend with use of that related to opioids. We talked a little bit about the CDC guidelines when I was recently presenting to them and what their organizations were doing about it, and it really hasn't quite moved to that level in those areas. You know, I think it's really important to know that oftentimes the prescribers don't know their patients are visiting multiple places. And, you know, obviously the patients don't know that this is addictive or potentially harmful. In 2013, you can see that family physicians wrote 15 million prescriptions. Internal medicine did 13 million. I mean, that's half the opioid prescriptions in a year. 60% of deaths occur in patients when they're issued based on prescribing guidelines. So it's not because some folks were bending the rules here. They were doing it the way they were supposed to. And I think most importantly, I'd like to stress that 55% of people who abuse prescription painkillers get them from friends or relatives. So it's only like 17% that actually get it through a physician's prescription. I think that's a staggering percentage, and we need to keep that in mind as I go through this presentation. When you look at some of the guidelines that are being developed focusing on the opioid epidemic, you can see that the Federation of State Medical Boards is involved. They partner with Substance Abuse and Mental Health Services Administration to revise how opioid prescribing and office-based opioid treatment policies are developed. When you look at the American Society of Addiction Medicine, they put out national practice guidelines for medication with the American Academy of Pain Management. The reason they also developed a guideline was they wanted to assist in the evaluation and treatment of opioid disorders. And although there's other guidelines out there, none of it actually included all the medications used at the present time for this type of treatment for pain. And a lot of the guidelines out there, they're not addressing adolescents, pregnant women, co-occurring psychiatric disorders, and other comorbidities. So, you know, they really have a little bit of a different twist than what you might see with the CDC guidelines. You know, and I just recently gave a behavioral health presentation, and you really have to think about comorbidities as well as other behavioral health aspects that might be impacting the opioid use. And we'll talk a little bit later about some of the CDC guidelines that have come out. The prescription drug monitoring programs, you know, they've actually been around a while, but with this, increase in attention and media attention and government input, they are now in 49 states. I noticed that New York actually requires that they check this before prescribing the painkillers, and they saw an actual drop in those who are seeing multiple physicians. There's a lot of issues around the prescription drug monitoring program, and I'll talk about that in a little bit. St. Joseph's Regional Medical Center in New Jersey started an alternative to opiates, and they're really trying to work hard about substituting powerful pain medications with varying alternatives. You know, there's a new way of thinking that they believe starts in the emergency department. So they're treating ER patients with these severe issues of kidney stones and broken bones. They're thinking more first line with nerve blocks and anti-inflammatory medication and other non-narcotic pieces. And they feel that, you know, they've been able to show that 300 people have been successfully treated, and the numbers are growing. Another example that I really, this is one worth really digging into and reading through. They've published a lot about this. The Massachusetts Hospital Association actually formed a task force and developed recommendations, 9 of them, 9 best practices for managing opioids in the ED. And they already have 51 of their members implementing these recommendations. They've been able to show a 25% decrease in prescriptions. And phase 2 will be all about developing best practices for other areas within the organization where obviously pain prescriptions are written. And they have a lot of, if you look at their story, they've outlined very clearly the things that they've done in the emergency department to try to attack this problem. Another example is putting a drug box near one of the main entrances in one of their hospitals, and it's sad to say, but they collected over 40 gallons of unused meds in 1 month. Another health system up in Wisconsin actually started this in 2008, and what they decided to do is take one pain specialist, and they had him educating primary care physicians within their network. He was there to help them better understand the patterns of battling chronic pain and how to treat it. They then developed some systematic guidelines that are being used without. They have a committee that they've been using, obviously, all along to address this epidemic, and it actually includes all stakeholders that could be possibly involved, including patients, which gets back to that patient-centered care piece and having patients in your advisory panels and other areas of the organization. There now is a National Take-Back Day to remove these unused prescription drugs from the communities. The DEA has collected more than 5.5 million pounds of medication. Think about the waste there, the amount of waste and the cost of that waste. The DEA also finalized a new rule making it easier for communities to establish ongoing drug take-back programs and trying to get rid of the stigma of the criminal piece of this. I know local police departments have a drop box for citizens to deposit their unused expired prescriptions. This goes back as far as 2011. I can tell you in my own community, an alert just went out the other day about, prescription drug take-back day, and they had some staggering statistics about, the amount of drugs that they've already been able to get within 1 year of implementing this program. Let's talk a little bit about a case study. I'm going to bring in another aspect that I don't know. It used to get a lot more attention in the media and in journals, but this is an actual claim, and I'm just going to walk you through how some of the gaps here and the allegations, so we can learn from this process as we move forward, as we're trying to attack this epidemic and pain care. So Mr. Smith sought out a physician for treatment following a spinal surgery, and like a lot of folks, he stopped making appointments with the surgeon because he didn't feel that treatment was helping, and having had some personal experience here, they just like throw you the prescription and they're like, okay, yeah, you'll get better. Just let me know. And then they don't follow up with you, and there's no instructions, and there's no continuity of care. So he found Dr. Winters. Now, this Dr. Winters is unaware of the other providers treating Mr. Smith for pain. Dr. Winter never obtains Mr. Smith's medical record. Dr. Winter never contacts the surgeon to discuss the current treatment plan. He takes a brief history, conducts a physical exam, doesn't ask any deeper questions, assesses this patient's level of pain without even using a visual tool to confirm. Now, Mr. Smith considered his pain chronic, even though the surgery was recent, so it really, probably hasn't quite reached that level yet. But he was never educated on acute pain versus chronic pain. He was never educated on expectations. So, like a lot of folks out there, they think that they should be pain-free very quickly. And no one outlined to him the amount of pain, the duration, post-surgery, nothing. There's no discussions about this. So Dr. Winter goes ahead and prescribes 50 micrograms, which would be per hour, for fentanyl patch, and he gives him 5 at one time. Dr. Winter does not ask what other meds Mr. Smith is taking or has access to, and turns out Mr. Smith is currently taking Norco. 5 at once, well, it's really hard to monitor the effect of that if you don't have any follow-up appointment made. Some would tell you that because of the rules on the black box warning, 50 micrograms was really too high for a first dose. He hadn't really been on Norco that long, but remember, Dr. Winter doesn't even know he's on Norco, so it's definitely the wrong amount to be giving this patient, who in his mind probably has no opioid tolerance built yet. There's no documentation here. So here's some of the gaps. There's no documentation on how to administer the patch and transition off the Norco, because he didn't know about the Norco. What symptoms to watch for. This is a very potent drug. You know, I mean, obviously it's just absorbed through the skin, so it is a lot riskier than, in some ways, than the oral medications can be. They didn't, no instruction on when to call the physician or when to go to the ED. The instructions there's no instructions to call Dr. Winter if you're going to take other medications, because if you know anything about the fentanyl patch, the other medications can really impact the absorption of this. They don't even check to see what his comprehension of the discharge instructions are, and there aren't many to begin with, clearly, because we don't have documentation of this. And he didn't review any pharmacy profiles. You know, he doesn't discuss the symptoms of toxicity. Antibiotics can change the absorption of the patch. So there's no proof of anything here. And the legal issues in this case become prescribing fentanyl without establishing the indication for the drug, which is a very big push today. Failing to use less potent drugs for pain control, so there was no discussion or documentation of trying alternative methods before jumping to this. Failing to prescribe the drug according to the manufacturer's warnings, which I'll get into in a minute. I mean, you got to know your black box warnings and your drug labels. Failure to prescribe the opioid without establishing the opioid tolerance, like I said before, and not looking at the medical record. So these are all the allegations that come up in the case. You know, you have to establish that less potent drugs are not working first, and that you've tried alternative therapies maybe. So, and obviously you should be assessing the past medical history for addiction and abuse, because that changes the scheme of things on what you might prescribe. This case settled for about $400,000. If you don't follow the suggested guidelines out there in the literature and on the label, you're obviously going to run into trouble. And now that there are so many guidelines out there, it's really important, yet difficult for providers and those, you know, practitioners prescribing. They really have to stay up to date on it, because it's in writing and it's easy access for the plaintiffs, so it would be easy for them to bring those in a case and hold them against the provider. In this particular case, we have a 77-year-old female who was given prescription for Vicodin for sciatic pain. She took about 4 doses daily for a week, and the lower dose, but she was still in pain. Her primary care physician called the pharmacy and prescribed fentanyl, again, the 50 micrograms, to be applied every 48 to 72 hours. A friend picked this up for her and was given the 5 patches. The pharmacist did not provide any education regarding the proper use of the patch. And then the woman's friend helped her place the patch on the buttock. I mean, they didn't know how to apply this, and that was the site of pain. So, right, you know, that makes sense, common sense, put it where it hurts. When the woman went to bed, she placed a heating pad on her lower back buttock area, of course, because that's what she's already been doing and been told to do. And after not hearing from her in 2 days, the friend went to check and found the woman dead. There were 3 fentanyl patches left in the box when they found her. It looked that the second patch was applied without removing the first patch. The pharmacist did not question the prescriber about the initiation of the fentanyl therapy at that strength. The physician prescribed it over the phone without examining the patient. Should not be doing that, or educating her about the drug. And the patient was never warned to avoid applying heat over the patch, because once again, that can increase the absorption rate. When you look at the black box warning and the labels here, you can see here that this is for moderate to severe chronic pain. It cannot be managed by other means, is when you can use this. It should only be used in patients who are already receiving opioid therapy and have demonstrated opioid tolerance, which when you research that, obviously that too is some debate about what that means, but she wasn't on it very long when they did this. You want to do the total daily dose low and slow. It's different for patients who are considered to be tolerant. Because of serious or life-threatening hypoventilation, it's contraindicated in those who are not tolerant in the management of acute pain if it's only needed for a short period of time. You have to be careful with postoperative pain, out-of-patient or day surgeries. So obviously, in both of these cases, you violated what the black box warning is, and clearly it'd be hard to defend you if you don't know these and you're not following them. Some other common weaknesses when doing regarding pain management is that sufficient follow-up and examination. After each encounter, there should be some discussion about the documentation of corresponding symptoms. This is often missing. You want symptoms that establish, justify the plan, showing if there's improvement or not improvement. The discharge instructions really need to spell out that are given to the patient and discuss documenting comprehension. I mean, part of the problem here is the lack of awareness for so many folks. I mean, the epidemic is not just a practitioner issue. This is a community issue as well. We'll talk about it a little bit later. There's really a lack of comprehension and awareness, and obviously it starts with practitioners being able to provide that education because folks rely on them, but we also should be giving them other material to enhance that education and comprehension process. There needs to be frequent monitoring with visits, exams, refills. You have to be very careful about that, how often, why you're refilling. Are you looking at pain levels? Are you reevaluating? Do you have a plan that shows there's been discussion, that you've collaborated on what the management's going to be? So these are all common issues that you're going to see in the allegations that you see in pain management, and we'll talk a little bit further on some strategies. I think it's important that I spend a little time highlighting the guidelines that are out there that are based on more of the governmental agencies, the professional agencies, and things of that nature. So when you look back at the FDA, so even though this opioid epidemic has somehow now overtaken the media, it's actually, been known about and going on prior to this last year and this year. In April 2011, the FDA and the White House had a campaign against it. They tried to develop these risk evaluation and mitigation strategies. And then the following year, they released a risk management plan for the extended release long-acting opioids, like the fentanyl patch and things of that nature. And here, the drug companies are being required to make educational training available for the healthcare professionals on safe prescribing. That's part of the risk evaluation and mitigation strategies. This is for them. So then they said they would reevaluate it. So the OIG comes back in 2013, and they call into question the effectiveness of the FDA's report and the program. They're finding that a lot of folks were not meeting the requirement of the development of their programs, the follow-up of these REMS programs, and documentation. It looks like they're having trouble keeping track of all that are out there. So there's a lot of weaknesses within these processes for these risk management strategies. And then just as recently as March, the FDA changed some safety labels. They're going to have it so that opioid medications are now required to include that box warning that cautions the patient about the misuse, the abuse, addiction, overdose, and death. See, we never talked about addiction before. Nobody gives anybody a pain prescription and says, hey, I need you to know that this might help you with your pain, but you could also become addicted, and here are the signs. And, oh, by the way, you could overdose on this, and maybe it's because of other drugs you're taking as well, so let's discuss how that is playing out. And obviously death. I mean, it's certainly, I've been both a patient and a healthcare professional. You don't see these conversations happening. Obviously, there should be that drug interaction warning. I mean, there are some people take it very lightly. Oh, I could have a couple drinks with it. You have to really think about, what could an antibiotic do? So it's important that we start the conversations. I mean, obviously, just having a label isn't going to be enough, but it's the beginning steps. And of course, it's for those who might be dependent on the medication, which means they have to know they're dependent on the medication. Immediate stoppage is obviously very dangerous. And I'll just point out, I don't know if you can see this, but I do have some of the sources for some of this information on the individual slides. So, you know, if at some point you would like a copy of this presentation, obviously you can reach out to me, and that, you know, that you would have some access to that from here. The Joint Commission, improving the quality of pain. Now, they've been working on this since, I mean, this goes way back to early 2000s, even the 90s. So, you know, here's what they said should be happening. That they educate all licensed independent practitioners on assessing and managing pain, that they respect the patient's right to pain, because, you know, in earlier times, we thought pain was a figment of imagination, not to mention that physicians were, you know, and other practitioners are probably afraid to prescribe it because they worry about criminal charges. And a lot of that has loosened up over the last, like, 7 years. They want you to use methods to assess pain that are consistent with age, condition, ability, to reassess, respond. And I guess the reason for bringing this up is that we've seen that there's a debate out there now on what is causing the epidemic, and I'm not taking a stance any way, but, you know, some folks believe it's exacerbated by the problem of some of the guidelines that are out there. And if you read these, they seem pretty benign, and obviously they were looking for treatment strategies and using alternative non-pharmacologic approaches. You know, some have focused on the HCAP surveys because there's 3 questions on there that are very, very focused on pain, and it almost makes you think, it convinces patients that they should be at 0, and I think that trying to get to 0 is a myth we need to really educate folks on, that that's not necessarily what's going to, you know, to be the result here. And that might have added pressure on folks. You know, and at one point there was a lot of push to be very aggressive in treating pain. So there's a lot of controversy out there about how this epidemic came to be, but I don't think it's any one thing like anything else. I would say it's the lack of awareness and understanding and education that's led to these problems, along with other cultural, societal pressures. You know, there were some misconceptions accused of the Joint Commission. They actually provided a very strong response to it. They definitely took it very seriously. And at one point there was the requirement that you have all patients have to have a pain scale assessed. Now, that was eliminated back in 2009, and all programs except behavioral health accreditation. So patients in behavioral health settings were thought to be less able to bring up the fact that they were in pain maybe, and therefore required a more aggressive approach. So it still stands that that's a requirement for them. That's just one area of guidelines that, you know, and a position that's out there. In 2011, the IOM actually has a report out that led to the growing recognition of the impact of pain on health, productivity, and, as we know and hear about all the time, population health. The government then got involved, HHS did, and they put together a national pain strategy, which I mentioned earlier, but it was more comprehensive because it gets into the population health piece. So you're looking at research, prevention, and care, the importance of really digging into disparities on the economic and cultural level, service delivery, which I mentioned earlier, thinking about those folks who are in the rural community versus urban, and payment. I mean, a lot of the non-pharmacologic areas are not covered and are expensive, so folks don't go that route. There needs to, they have a push here for the professional education and training, starting this in nursing schools, starting this in medical schools. I mean, starting this at the ground roots of this, obviously very important. And public education too, as I mentioned earlier. They recommend a development of a web-based pain education portal that would contain up-to-date comprehensive education materials for practitioners. There would be training efforts through that made in coordination with HHS efforts to develop tools. So the national pain strategy, part of that is to work together with them to provide these You know, pain is one of the most common reasons for healthcare visits, and nonetheless, most healthcare professions, education programs devote very little time to the education and treatment of pain. You know, we know that there are strong indications that pain receives insufficient attention in virtually all phases of medical education. So the IOM report actually found that education is a central part of necessary cultural transformation, right? We know this. This is part of the IOM mantra on just about everything. So they also pushed for a curriculum that would better support the education of practitioners. The CDC, that was probably the one that's gotten the most attention in the media. You know, the draft came out, then there was this hard push, get the final out. And it has 12 recommendations, and I don't know how many of you have searched out there, but you know, you could search this and find many different versions that actually are published by the CDC on these recommendations. They basically fall into 3 categories, because I'm not going to, you know, we don't have time today to go through all the recommendations, but it's determining when to initiate or continue the opioids for chronic pain, the selection, the doses, duration, follow-up, and discontinuation. So there's a lot of information on that in here, as well as the National Pain Strategies report, and of course assessing the risk and addressing the harm of opioid use. Now, within each of these categories, they list clinical reminders to go along with the recommendations, which for practitioners, those will probably be easier to remember. You know, and they can refer back for more detail to those other recommendations. And, you know, they also put in some recommended treatments for common chronic pain conditions, trying to streamline and, you know, make there be some consistency. And they also provide a checklist for prescribing opioids for chronic pain and things to look at. The CDC has also put out a picture handout version from this formal study that I think is really helpful. It allows you to use it for education of patients, for educating your staff, for educating practitioners. It kind of puts it in a nice, clean way. You know, I find that, you know, you could read the long research version, obviously, but that's another resource for you as you're trying to put your arms around this and deal with this issue. There's advocacy groups out there. I mean, I could not believe how many different pain societies, advocacy groups, guidelines. I mean, like I said earlier, there's an overwhelming amount of recent stuff being put out. So this particular advocacy group, it's a state pain policy advocacy network. And here, they actually try to monitor and track the pain activities. So they're in different ways, looking at overdose, and they're focused on public safety, obviously. I found this astounding, though, that there were 250 bills spanning 46 states on pain in 2015. I mean, goodness gracious. I mean, no wonder the government sometimes has, you know, hard time narrowing it down. Obviously, we can imagine there's a lot of different stakeholders here with different aims and different opinions on what would be the, you know, the best approach. So, you know, their goal, though, really is it's to look at access for integrative pain care. So we talked about this a little bit ago. You know, it's not covered. It's not easy to find. There aren't a lot of folks out there. And how do you know if they're trained properly? And how do you know as a patient if that's someone you could trust and go to? And how do you know that it's not, you know, that it works? It's not voodoo medicine. So, you know, they're actively collaborating with other organizations to address this issue to get, you know, they're looking to get coverage through insurance companies. They're advocating for all these things that we all know that if you really want to treat this pain issue, we have to take a more holistic community approach. They're pushing on the pain education for clinicians. They're partnering with certain groups that they know you know, have a strong voice here to advocate for the continuing education and making sure that education is actually relevant and useful. And of course, improving the effectiveness of these prescription monitoring programs, because a lot of those are not easily accessible and effectively able to be used. So now we're going to get into some of the risk strategies, and you're going to see that I try to take an approach where we really look at patient encounters and education and training. So we'll start with the obstacles. we have to get back to the unrealistic patient expectations, and that comes with awareness and education. Like any risk management issue, awareness and education is where it starts. It's an iterative process. We can never get tired of our message. We can't guarantee zero pain, and that's really hard, obviously, if you've been living with pain for a long time, or it's a newly acquired, thing for you, and you're not sure what's causing it. I mean, you can imagine that there's a lot of psychological, emotional pieces that go along with this as well. Barriers, there's a lack of research. I mean, when you look at tools for detecting opioid abuse or disorders, there's no consensus on what's really effective and useful. There's the beginning happenings now of establishing guidelines for certain conditions, being more specific to those disease processes or the causes of that kind of pain. There's the beginning stages of clearly articulate practice standards and tools, but as you can imagine, there's going to be a lot of varying of opinions here. This is obviously a complex issue. This isn't going to get fixed overnight. And the accountability for pain management practices, which obviously there really hasn't been a whole lot. We have to combat the societal attitudes about pain. I mean, this is the same as our behavioral health population, who, by the way, often have addiction and abuse issues with opioid medications, is that there's this stigma here, and we're treating it not as a disease, but as more of like, it's your problem, we can't help you. So we have to really work hard on changing those attitudes, and those attitudes are pervasive even within our healthcare community of providers. If any of you have ever worked in an emergency department, you know that those patients coming in with these types of issues or the mental health issues, that there's a stigma and an immediate attitude, unfortunately, that we have to find a way to break those down and really be more compassionate with these patients. The lack of education goes along with it. We really, there needs to be a big push on the general public and people with pain and what it means, really educating folks, because I think if we involve the communities, we have better chance of saving lives. And we have to, like everything else and all the other risk management issues, we have to improve communication between the provider and the patient. We have to find ways to break down those silos, to not be afraid, to not think that if we tell them something that's going to turn them and they're going to become addicts because of what we told them. I mean, transparency is important here. So what are some strategies you could use for your patient encounters? Well, I say establish doctor-patient relationship. I'm sure some of you are laughing like, well, yeah, that's common sense, but no. There's plenty of cases out there where this was done over the phone. There was no actual, it was not truly established in the way that it should be in order to truly evaluate. You can't recognize behaviors that are going on with a patient if you're not physically in front of them, or even at least Skyping, telemedicine type things. So, I mean, you're going to miss a lot if it's just over a telephone. We're not screening enough for the history of abuse and suicide. When you look at malpractice suits where patients overdosed, 80% had evidence of current or past substance use disorder. And 40% of those same cases, the patient had a mental health disorder. I can't stress enough that while there's this heightened awareness with the opioid epidemic, we need a heightened awareness with the behavioral health population, because these two cross over a lot. That's why we have to address these coexisting mental health conditions, and we're not necessarily educated in the way we should be to address those coexisting mental health conditions, and we're not educated the way we should be on opioids. So you can see why this is a huge problem and a huge undertaking. I mean, obviously, anxiety, depression, post-traumatic stress disorder. I mean, a lot of times those folks, unfortunately, will seek to numb the pain, and obviously opioids can help with that. I don't think that there's enough stress on the non-opiate therapies, and having personally gone through this, I think, they were like, oh, here for your back pain, do the anti-inflammatories, and then in 2 weeks it didn't work. So they, okay, here, take a narcotic. And I'm like, seriously, really? What about physical therapy? No, that won't help you. I mean, it scared me to death as a healthcare professional, aware of the risk of addiction. I actually decided to put myself back on those anti-inflammatories because I didn't like the other medicines. And it just was the fact that I wasn't on them long enough, they actually started to work. So, you know, we're just too quick to jump to the next level and wanting to make patients happy, I think. And I wasn't pushing for it, but, you know, so, and I have knowledge. So, again, we need to educate and consider those other therapies. You know, no one's ever established any treatment goals with me or followed up to see how I was doing, what worked and what didn't. So it's important. We've talked about this before with pain care management and risk management issues. This is not a new thing, but I think it really, you know, the opioid epidemic sheds a light here why it's really important to have these goals with all patients, and they need to be realistic, and they have to look at function. We need to document that treatment plan. You need a really good informed consent. That's nothing new for risk management strategies, but, you know, obviously very, very important here of discussing the risks and the benefits, and agree for treatment. What are you going to agree on together while respecting, you know, that the physician obviously has to manage these therapies, but if you don't get buy-in from the patient, you're not going to be successful. And you have to do re-examination. You have to follow up with those folks and see how these therapies are working. This should be included in the process for each and every consultation and treatment. And I know some folks only have 15 minutes with their patient, but obviously 15 minutes could save a life here. So, you know, we have to really think. When you think about non-opioid therapies, there's also a lot more literature coming out about cognitive behavioral therapy, obviously the use of exercise. Now, some conditions, exercise only makes it worse, so it kind of depends on what we're talking about, and you need to have the knowledge to understand what would work. Other medication options, physical therapy, so these have to be individualized goals to support the selection of therapies. You can't have, you know, off-the-shelf canned set of goals here. It really needs to be talked about with your patients. You got to know those black box warnings and share that with the patient and help them understand what those really mean. You know, all of us in healthcare and those of us as patients have to understand the immediate release opioids versus the extended release long-acting ones. I mean, clearly there is a risk of respiratory depression and overdose here, and no one has ever told me that, or I'm sure any of you. You know, you'd be lucky if you actually got that. And how many people do you think actually read the extremely long pamphlet that comes with the pharmacy package when you leave the pharmacy? So, use of other medications, the realistic benefits, we have to discuss these things, and the duration. And discontinuing medication if benefits do not outweigh the risk. I think that's a shift here. That's not something I think we're comfortable with, but we have to start having those conversations because of the risk of addiction and abuse. And you really need to look at the review of the treatment efficacy, so that there needs to be a comprehensive assessment of the patient and how that's working for them. There are tools out there for these purposes. Some are specific to certain industries, certain disease processes. There's a lot of ones out there that, you know, as a group you can decide what you think works best for the patients you encounter. Renewals should be done during patient encounters. If you have to renew without a visit, you need to make darn sure that you've made an appointment and they're following up with you. And you give them a limited supply so that they obviously have the urgency to follow up with you. I know that these days now, if you need a renewal, you have to go to the doctor's office to get the paper prescription for the narcotic renewal, which is really inconvenient. So obviously trying to stem the fact that the wrong person maybe is getting it, except at the end of the day, anybody can go to the pharmacy and pick it up for you. So there is that obviously that's been occurring. You can't just, you know, call it in through prescribing. You have to keep warning these patients. You know, I think because we're so used to now it's okay to use pain meds for pain for chronic patients. It's okay to drink. Maybe you could have a drink with the drug and it'll be okay. I mean, I think we really have to stress the fact that your body doesn't know how you would react to it, and that you really shouldn't take those risks. And alcohol socially is a problem. You know, you should consider trialing the opioid therapy and monitoring it for its benefit in the beginning for someone where it's new. You have to keep yourself up on the risks and benefits. And the periodic drug testing is being implemented in a lot of states and a lot of places. And you're looking for other opioids that you didn't prescribe, or dosages and dangerous combinations. And there are a lot of folks who were like, no, I don't have to worry about this patient. We shouldn't demand the urine drug testing to identify prescribed substances. And unfortunately, they were surprised to find out that those patients they thought they knew so well had cocaine or meth or something else in their system. So, prescription of drug addiction doesn't know a race or an economic level, or, it's not necessarily the homeless person you think on the street. A lot of times it's so easy to conceal that it's in places where you'd least expect it. So we have to be cognizant of that. Review state prescription drug monitoring program. One of the things I wanted to point out here, there's a lot of challenges because there's limitations in interoperability. A lot of folks are not able to access this in real time. There are HIPAA high-tech concerns. There's, like in North Carolina, apparently prescription info submitted is privileged and confidential. Okay, so that doesn't help. You should enroll and access the respective state programs in advance of the areas around you. Try to utilize these. They are actually literature out there that they're putting money and effort into improving these so that they are more effective and more useful. And you should check this out before treating, and before developing your contract or your treatment agreements. And don't forget about psychiatry, mental health specialists. Don't assume that this is a one-faceted thing. It's just pain. There's always a potential for depression or some other issues there. And you know what? Don't hold on to them if you're in primary care or family practice too long. Refer them to the pain specialist if it's getting too complicated. Education is key. We have to educate the initiatives delivered in the community and schools. We have to educate the medical schools and nursing schools. We need to educate. I can't stress this enough. The prescriber training on opioid abuse and disorder treatment. The President announced in October of last year that a commitment by more than 40 providers, 540,000 providers, will complete training on this in the next 2 years. And apparently after 3 months, they already had over 66,000 providers to do this. And you know why? Because we all want to help do this better. Nobody wants this to have the outcome that it has, occurred. There's also a piece with support from the administration. They're developing strategies and tools and skills to teach you how to start a conversation with patients about substance use, how to manage it. So they're putting together tools that actually will help you on the words to say and how to talk to the patients. And 10 states have already passed legislation requiring the training for prescribers. We'll go back to the federal medical boards, and I want to point this out because I think it's important that it clearly states that the state medical boards will consider inappropriate management of pain, particularly to a departure from accepted best clinical practices, including but not limited to inadequate attention to the initial assessment to determine if opioids is appropriate. And what this means, the need for education on understanding pain and treatment options can't be deferred anymore, can't be ignored. You got to know what you're prescribing and understand its effects. Education is imperative on what's clinically indicated. And oh, by the way, the plaintiff attorneys are going to see this too. So they're going to use this against you in the lawsuit. So hopefully you heed that warning. Here's an example of a patient history trying to really, I don't know how you can see it, but kind of trying to get into the characteristics of pain management strategies. There are a lot of tools out there that can help you modify your history. I'm sure a lot of the EMRs have the capabilities in doing this. There's other multidimensional tools out there, and what's funny is a lot of these are like old, tried and true, and I was like, I wonder if they're really still being used, but all the research I found is that there's still definitely these tools are being used in places. They're just simple initial pain assessment tool to guide you through the initial assessment of pain. This is often used in cancer treatment centers. It's been around a long time. The McGill Pain Questionnaire has three major classes of word descriptors. So it's looking at sensory, affective, and evaluative. So it's looking at all the aspects that incorporate pain, and it has an intensity scale too, and other ways to determine the properties of pain. And then effective evaluation and treatment of pain, cancer pain. There's valid tools out there for that. When you look at the Memorial one, it's a simple instrument designed to provide rapid evaluation, and it's like a card size, so it's a quick, easy way to look and remember. And of course, I'm sure all of you have seen the pain drawings where you have the patient circle where their pain is and sort of describe what's going on. As far as non-pharmacologic goes, physical approaches have a lot to do with biofeedback, relaxation, imagery, psychotherapy. These things do work. Obviously, physical rehab, we know what those are, but we could include maybe acupuncture and cryotherapy. Surgical, you know, injections of chemical or application of heat or nerve blocks. Those are procedures that are happening more and more now. There's actual pain clinics that will do this that you can get referred to. And then for some of the neuro pieces, there's some ablative surgeries that can be done to try to like kill that cycle of pain. It wouldn't be a good risk management professional if I didn't mention we can learn from our data. So you're collecting medication errors. And the Pennsylvania Patient Safety Authority published, you know, when you look at hydromorphone, the wrong dose or overdose was 16%. The wrong drug. I mean, these numbers should not be occurring, as we all know. But now we can see that we're not helping, obviously, the epidemic here. And we have the data right in front of us already. A lot of the overdoses that occurred during the prescribing involved orders for the wrong dose and frequency. And, you know, they obviously had central nervous system and respiratory effects. And it looks to be that 65% were preventable. So we have data we can start with internally within the hospital settings and office practices. Don't forget to learn the signs of opioid abuse, you know, failure to experience pain relief from these high drugs, or nodding off, falling asleep during inappropriate times, lying obviously to obtain them, or getting it from multiple providers, and deterioration or lack of functional improvement in everyday life. Exaggerating the pain, that one's kind of a hard one to know, and then of course forgery. Training's really important here. You really should develop the elements of a training program, pretty simple. Have the review of policies and procedures as part of your program, education on early recognition of behavior and warning signs, awareness of risk factors, and this should be, you know, all healthcare personnel. It should be something that everybody gets educated on an annual basis. Again, communities need to establish overdose education, and there's a big push on the naloxone distribution, so giving it to friends and loved ones. There's some brief training can be provided with these emergency kits, and programs have already been shown to be effective and cost-effective. And this has been going as of at least 2010, where, you know, that they've been able to provide this and reversed a lot of overdoses. Hundreds of law enforcement agencies are carrying it, are trained now, so that prior to 2012, six states had the law. And, you know, there was that fear of criminal liability for a person who took steps to assist an overdose victim. And as of February, 46 states and D.C. enacted a statute expanding access to provide Good Samaritan protections. I can't say enough about raising awareness. We have to dispel those myths. We have to inform the naive. We have to change our prescription patterns. Options for alternative pain need to become commonplace. We need to identify and find new ways to manage pain. There's a lot of research out there on other medications that might help with the addiction of the pain. Research is definitely being done. We just need to be aware and abreast of the common stuff. Bringing task forces together, like I talked about, in some hospitals have already shown that there's, you know, that this can be done here. Kaiser Permanente shows that they were able to decrease the prescriptions by 85%. So, you know, it's obviously possible. It's going to be a paradigm shift, though. Treating addicts like patients, not criminals, that's a change. Recognizing chronic pain as a disease in its own self, and, you know, it's an illness here. We need to provide services, not deny them. We really need to be compassionate about it. And with that, I have a few resources for you here. And thank you. Here's my contact information. If you have any questions, please feel free to submit those through the chat function. One of the things that the questions being asked is about this risk of heroin, and I didn't spend a ton of time on the epidemic, but I think that's another piece of education we really need to be talking about, because what happens is a lot of folks, when they no longer have access to the pain prescriptions and they're addicted, are now seeking out heroin, and it tends to be actually easier to get, and it tends to be obviously can be more lethal, and it's cheaper. And in talking to some of my rural communities too that I've also worked with, it's in some of their bigger cities. It hasn't reached the smaller towns yet, but I can tell you, when talking to my teenagers, that it's in the high schools, and so it's everywhere, and it is definitely something we need to talk about as well. So availability of education on that is obviously important. So. And we need to dispel the fears of coming off the pain meds and helping those folks with addiction know that they could, what they can do with their lives. So are there any other questions? Well, I thank you so much for your time and attendance, and I wish you all to have a great day.